So my subject today is progress that's been made to refine movement analysis so that we can maximise recovery. So it's motor recovery as a basis for functional recovery. I acknowledge contributions of many of my colleagues. We work as teams. I couldn't possibly do any of this all on my own. So I just want to applaud my teams who have contributed much to this programme. The pictures you see here are deemed to illustrate what we're looking at in terms of movement analysis. That top picture of two legs that is orange and red, that is somebody standing up, and you've got lines all the way up showing snapshots of that movement. The person below, we're very interested in their ankle trajectory, because if we can understand ankle trajectory, then we can retrain walking to get that trajectory back again. There's an awful lot of thinking goes on in our lab. We've got lots of, I'm working my way along, lots of measures that we can make, but the prime focus of it is people's function, getting them back the motor recovery they need in order to be doing those everyday tasks that we need to do for everyday independence. We know physical therapy works. Physical therapy, if you receive physical therapy versus nothing, you're 80% better off. It's a huge effect size, bigger than most medical interventions. But we still have some way to go. This year, the James Lind Alliance and the Stroke Association published their Stroke Priority Setting Partnership priorities. And a key one here is what are the best interventions, including exercise, to improve strength and fitness, promote recovery and prevent further stroke in stroke survivors. This morning, I'm going to be focusing on promotion of recovery in stroke survivors. So driving better motor recovery or movement recovery with physical therapy. We know that a brain responds to what the behaviour actually is. Behavioural experience, we know from many neuroscience studies, is the most potent modulator of neuroplasticity, brain plasticity. But it's not always beneficial, it can be maladaptive. So how do we know as therapists in clinical practice, and how do we know as stroke survivors after having suffered a stroke, whether the brain plasticity that is being enacted in our brains that we can't actually see is beneficial or not? Are we having neuroplasticity to drive the motor recovery, or are we getting motor compensation? So there's been a lot of thought into what is motor recovery and what is motor compensation, starting about 10 years ago by Mindy Levin and her colleagues. So a working definition of motor recovery is the reappearance of the movement patterns that were present before the stroke. If you walked with a limp before the stroke, you're unlikely to be able to walk without a limp after the stroke. So it's not being unrealistic, but it's trying to get back to where the person was before they had the stroke. Whereas compensation is the appearance of new movement patterns after stroke. So, for example, let's think of another pathology. Let's think of somebody who's had a hip replacement. After the hip replacement, they might actually limp, which is a motor compensation. But gradually over time, as the pain subsides, as muscles improve, we get recovery, motor recovery, the reappearance of the movement patterns that were present before they actually had the pathology. But we need to consider that although compensatory movements do help people to do things in the short term, it might cause long-term problems such as pain or joint limitations, permanent changes in behaviour. And we know from neuroscience findings that compensatory movement early after stroke may actually hamper later recovery because of the injury-induced neuroplasticity that's present in the brain. It's very difficult to unpack that, to turn it back into motor recovery in that early phase. So more recently, there's been a series of consensus meetings by international experts, and the consensus is that movement recovery is best measured using biomechanics, movement analysis. So how do joints move through space? How much force is exerted by movement? And how are those muscles activated? And the consensus internationally is that biomechanics can distinguish recovery from compensation. I've got a short video here. It's a bit of a promotional video, so please bear with me, but it gives you a much better visual idea of what I'm talking about.
Our stroke rehabilitation research programme is focused on how we can further improve physical therapies so that even more people make a good recovery. To analyse how people move, we use infrared cameras to track markers placed on the body. In the animation industry, this technology is used to produce lifelike movements of characters in films and computer games. For our research, we reconstruct the actual movement of stroke survivors. We then produce measures of the normality of movement, such as the ability to move smoothly and the ability to change direction without losing balance. To analyse how movement is controlled, we place electrodes onto the skin directly over the muscles. This enables us to find out how good the brain-muscle connection is by measuring how long a magnetic stimulus takes to reach the weak muscles. We also measure brain waves during movement to find out how different brain areas are working and how they are working together. With these measures, we accurately detect changes that cannot be quantified by expert visual assessment. We are able to find out how damage to different parts of the brain affects movement ability and how specific physical therapies enhance brain recovery. More importantly, because these investigations are undertaken while stroke survivors perform everyday activities, such as walking, standing up from a chair, and reaching to pick up a glass, the new knowledge produced is directly relevant to stroke survivors' everyday lives.
Okay, so now you've got a picture in your heads of what I'm talking about. So, how do we use biomechanics to identify therapy targets? I'm going to talk you through this graph. Do not worry about it. Right, so what we've actually got here is a control foot, as they call it. That means somebody doing the task who has not had a stroke or any other neurological problem. The sound foot in the solid black line actually refers to the less paretic foot, and the dotted line is the more paretic foot. So the task was to place the foot on a target on the floor. This first target was placed in the midline, and people were asked to walk along and put their foot on the midline. So on the target on the floor in their midline. So as you can see, the control group were quite close. The less paretic foot was less accurate, and the more paretic foot was very similar to the less paretic foot. They then were asked to go at 15% of their leg length. So the midline, and then the distance was 15% of their leg length. I think, and then we had 30% of their leg length, and then we had 45% of their leg length. And I think what you can clearly see is that all the way through, the healthy adults, the people without a stroke, were fairly accurate. But as the target got wider, the stroke survivors were less accurate. So producing measures such as these actually provide us with therapy targets, and they also provide us with ways in which we can measure whether we're getting motor recovery or motor compensation. Here is another example. These were 20 people. They were on average about 2.5 months after stroke. And then there were 21 people who were over 2 years after stroke. And the button works. You'll be able to see the graphs. Do not worry about the graphs. Again, we'll talk our way through them. The red refers to the people early after stroke. The blue refers to the people 2 years plus after stroke. As you can see in all of these graphs, the solid lines are the the actual values. The dotted lines are the filtered data. Both early and late after stroke, people can improve motor recovery. And this actually throws a mantra out of the window, which is motor impairment doesn't change after the first 6 months after stroke. It does. You can improve motor recovery late after stroke as well as early after stroke. This was actually a reach-in task. So the first graph is the percentage of reach trajectory which is achieved independently. This graph here refers to the speed of the hand as it was reaching towards the object. This one's going down rather than up, but it still shows an improvement because it's about error. So error in the trajectory actually reduced, and this one is smoothness of movement. All things that are important in clinical practice as well. You can measure practically anything using biomechanics. And I've just put a plethora of examples up here, but we're not going to do it because it's rather like disappearing into a black hole. What we actually need to do is not get drawn into that black hole of, oh, we could measure this and we could measure that and we could measure the other, and we've got all this fancy technology for measurement. No, we need to think about movement analysis outside the laboratory. In clinical practice, and in clinical practice that includes movement analysis in people's homes. So I'll start with the laboratory. Very highly specialized cameras that emit infrared light which reflect off these little sensors. Those sensors then retroreflectively send the light back into the camera so it tracks it, and then it produces the movement of every joint in the body at 100 times a second. So really sophisticated stuff. Now, clearly, you can't get many stroke survivors early after stroke into these specialised laboratories, and there aren't very many of them. There's only 12 clinical movement analysis laboratories in Britain. Okay, so what can you do instead? Well, this is where technology comes to our aid. Okay, there's an awful lot of work going on around the world into markerless technology. So this is the Vicon system, which is this one we've just discussed, which requires to be done in a laboratory. But you can also ignore the markers because the markers here are actually projected onto the person's body from everyday technology that's available for all of us for gaming, the Microsoft Azure system, for example. And what that can do when you write the right software programs is also produce you with a model, a simplified model compared with the gold standard high tech, but it does produce a model. You can use it 3 meters away from people, and it can be portable. We're currently investigating one of these in our lab to test whether there's agreement between the measures that are made with the gold standard system and the measures that are made with the markerless system. And the markerless system just has, it doesn't even use the Azure. It uses a camera and a laptop, and that's all it uses, and people are sitting in a chair, reaching for a cup, you could place it in somebody's, we're hoping it's going to be in good agreement because they've got visions of being able to place that in people's homes and take it in the back of a therapist's car. And we've already tested using muscle activity, so using EMG electrodes to pick up on how the muscles are actually working. We have used that in a recent study that we've been doing actually in people's homes. And yes, you can get very good high quality data. So it's promising. But I'm going back to does this more portable stuff actually agree with the gold standard? And here I've got some graphs from, this is the gold standard looking at how the knee was moving. And this is the electrogoniometer looking at how the knee was moving. The patterns are very similar, needs a little bit more filtering of these data, but we do have portable systems already out there that can be using for motion analysis, and there are others that are rapidly coming up behind them. But what should we be measuring? I mean, this is another part of the black hole. I mean, we don't want to measure all of these joint motions. The clinicians just don't have time to do that. So after a lot of thinking, we're beginning to come up with some targets for measurement and targets for therapy. And one of those is not how every joint is moving while people are walking forward and then we want to do a gait analysis. No, we have gone for the resultant of it, which is what angle is the tibia to the vertical during the gait cycle. We tested it on 23 people we had at baseline. Do not worry about the graph, I'll talk you through it. So this is the position, the angle of the tibia to the vertical when the foot first hit the ground. This is when the foot was flat. This is in mid stance. This is when the heel comes up off the ground, preparatory to the swing. This is the terminal contact, and this is the angle to the ground during swing. Now, doing this analysis allowed us to see how far away these values were for the stroke survivors at baseline, which is the blue line, and that was approximately 35 days after stroke. So the healthy people, so healthy in the terms of they had not had a stroke, were about, the angle was about -20 from the vertical, so as you can see here, whereas the stroke survivors had a straight leg, clearly abnormal. But an outcome 6 weeks later, that had improved, and it had improved further by the time we measured them again at 3 months after stroke. So it was statistically significant for these 2 points. So we're beginning to narrow down what actually needs to be measured. So we're doing some more work at the moment to look at how we could run this out into clinical practice so that we can measure tibial orientation to the vertical at initial contact and when the foot is actually flat on the floor. Another study that we've recently published was conducted with 91 people. Again, they were on average 30 to 40 days after stroke. And this time we looked at standing up from a chair independently. So people either put their hands, held their more paretic arm up, or let the hands dangle by the side. They were not allowed to push up from the chair. There was standby help in case they needed it, but when that standby help was actually needed, we did not use the data from those trials. And then we measured them again 3 months later. So what we actually looked at, this is known to most physiotherapists. You need to move, well, all physiotherapists, I would say, you need to move your body forward and then use your muscle power to get your bottom up off the seat, take you through rising till you get standing erect. So we were particularly interested in looking at that forward position of the centre of mass, and that takes account of where the whole body is in space, not just one particular marker. At the time when the quadriceps muscle, which is the big thigh muscle on the front of your thigh, was most activated. And we divided people, these 91 people, into 3 groups. Those that were never able during this 3 months to achieve an independent stand-up, those that were always able, and those that became able. They weren't able at baseline, but they were able by the outcome measure. And the important thing about this measure too is that it's relevant to everybody, whether you can stand up or not stand up, because it's taken during that very initial phase of attempting to stand up. So, and it's also relevant to those people who can stand up, because you can still improve it. And that's an important message. And this, sorry. Okay, I'll leave it like that. So as you can see, the never able, they were much less far forward when they activated their quadriceps muscle, their thigh muscles, than the people that were always able. And those people that became able were halfway in between. So this gives us an idea of whether people are going to be able to stand up later after stroke, if we can measure them early after stroke. And it also has provided us with a target for therapy, because part of our therapy could be at getting people leaning further forward and maybe using some biofeedback to get them to then activate the muscle at the right point in time. All work that we're taking forward. But the most important thing is, what do stroke survivors think of this? We did an exploratory study with 10 people who were of the age of the UK population that has stroke. They were 1 year after stroke, so they had lots of experience of rehabilitation. And we took people who had low functional ability and high functional ability. Okay, so after they provided informed consent, we took them to the lab. They came to the lab, they underwent a movement analysis in standing up and also in reaching for an object. We then interviewed them and asked them questions about whether they thought the movement analysis experience was acceptable, what could we have done better, what did they like, what did they not like. 5 to 6 months later, given a nice long space in between their 2 visits, we showed them anonymised graphs of the results of people doing the reaching task and doing the standing up task. And we gave them graphs of people who were finding the task difficult, finding the task easy, and those that were finding it in between, so that we could show them different representations, graphical representations of the same task in different people. Most importantly, none of our participants were shown their own graphs. We then had a conversation about what was understandable, what was not understandable, how we could make these representations more meaningful. Okay, so these are the sorts of representations that we showed to the people. The top line is about muscle activity that you pick up using the EMG sensor over the top of the muscle. And what we were picking up on was calf muscle activity. So that big muscle at the front of your leg called tibialis anterior on your shin. So we had right legs and left legs, and the task was standing up from a chair, standing and sitting down. These bottom graphs actually represent the knee joint angle. So sitting down, standing up, sitting down. So what did our stroke survivors think? Well, on the whole, they really liked it. We're getting comments back like, I'd be more interested in graph 2. They mean the bottom graphs compared with the top graphs, because they understood more what the graph was actually showing. People were feeling it would help them set their own goals because these graphs are very important and motivating. They'll be able to show them to their family and include their family in the rehabilitation. You can plot your progress. They understood the graphs. This person here found the task most difficult. It gives you a motivational boost if you can see how you're improving. Looking at the graph with the therapist would actually increase my understanding of what the therapist was doing, but we could make them better by using everyday objects and symbols. And the sorts of symbols that they wanted were things like these. They picked these are non-copyright images. So traffic lights, test tubes with different levels of liquid in the glass, whether your petrol tank is empty or full. And I liked this one in the middle where they said, well, you could show us which areas are actually working well and which are not working well by changing the colour of the actual joints themselves. So, in summary, for some reason it's not showing it again. 1 minute. Okay. We need movement analysis to recognise motor recovery from behavioural compensation. And sometimes it's quite subtle. The current systems we've got are very high tech and complex. They're required to be worked in a specialist laboratory, and there aren't very many of those around that are suitable for clinical investigations. And, you know, travel early after stroke can also be a real issue, and that will link to Avril's talk on fatigue. You can make thousands, millions of measures. Great, you can drown in data, but we need to find out what is very important to measure. There are technological advances for movement analysis systems that hold promise for taking this forward into clinical practice. Our focus is to undertake movement analysis in clinical, so hospital, outpatients and home settings where most rehabilitation actually happens, to help physiotherapists provide interventions that drive motor recovery and be able to track people's progress. And most importantly, stroke survivors like it. We need to do it. Thank you.
Okay, so my talk is about an area that I feel very strongly about, which is post-stroke fatigue. And at the onset, I'd just like to say that I have no key conflicts or interests to declare, except for funding around this area. But I would also like to say that I'm absolutely open to offers. So if anyone wants to offer me large sums of money, I'm absolutely keen to have a conversation with you. Okay, so the big $1 million question is, what is fatigue? What is this thing that people are talking about, which seems to be much more used commonly than it ever was before? And people used to talk about being tired, and they'd say they were tired all the time. But people now talk about being fatigued, and they talk about being fatigued in society more broadly. And actually, that is an issue for our patients. And I've put up something here on a slide that someone said to me. And this was a lady who'd had a stroke who was a secretary. And she was really annoyed about the fact that people kept using the word fatigued, because the difference was that when she was fatigued, she was absolutely finished. She couldn't do anything else. Whereas her colleagues would say, I'm really fatigued, but they were able to push through that, and she wasn't. So there is an issue about what we mean by the term fatigue. One of the problems is that there are so many definitions. If you want to grab a book, you will probably get a different definition from different researchers. But I really want to push one particular definition, and this is one that's actually quite old. But the characteristics of fatigue, I think, are threefold. First of all, you have someone with a chronic condition. This isn't something that is just overnight, lasts for a day or two. So it's chronic, and people feel exhausted. Patients often say, I feel wiped out. Secondly, it's unrelated to what people have just been doing. So for example, if you've just run a marathon, you probably would feel exhausted. But we are talking about people who perhaps get up, get washed, get dressed, and have to rest for an hour or so. So it's really not in sync with the activity. And finally, they don't seem to be refreshed when they have a rest or when they have sleep. And those three characteristics are really important if you're trying to make a diagnosis of a clinical fatigue. The other thing that we need to say is that people talk about fatigue as if it's just a bit bothersome and it's just something on the side. But we have known for many years that this is a big problem for people who have a stroke. And actually, there are very good research evidence coming through that many people find it one of the most distressing symptoms that they have. And this is even people who've had what we would regard as quite a severe stroke. They are saying, I can't move my arm, I can't walk properly, but my main problem in surviving and getting on with life is this problem about feeling fatigued. And it is really now becoming a priority area, but this is really something that's only happened in recent years and is actually starting to be recognised by the funding bodies. So we know from a national survey that Chris McKevitt did that people said that they had fatigue and they didn't get support and it wasn't recognised. We know that the James Lind Alliance has identified fatigue in the previous round, and actually the new priorities that have just come out put fatigue number 4. So that is really quite a high priority. And this, of course, is not just something we've got in the UK. If you look at international consensus, if you look at the action plan for stroke in Europe, fatigue is listed in rehabilitation goals. And if you look at the literature, for example, in Scandinavia, again, this is a patient priority area. So it's something that we really have to take note of. Now, this is an interesting slide. Like me, if you go to many research talks, most people usually say, I've got it, by the way, there seemed to be an RAF jet flying overhead my house, but I hope you can still hear me. Many people said at the beginning of their talk, there was very little research in this area, and that's why we decided to do it. So this is a real difference. This is Trinity College Library in London. And honestly, there is so much research on fatigue, you could drown in it. There is fatigue generally. There is fatigue research related to specific conditions. There is fatigue related to people doing neuroimaging, to psychologists, to therapy. There are so many papers and so much literature on research. It's very difficult to know how to look at it. So I'm going to give you a shortcut. If you want to look at any literature, I would suggest there are several bits of research that you should be looking at. So the first is, of course, Cochrane Systematic Review evidence. And the Cochrane Systematic Review that was done in 2015 by Wu, that basically said, we don't have any sufficient evidence to inform what we should be doing with patients with post-stroke fatigue. And the reason simply was that many of the trials that had been done had used different definitions of fatigue, they had did interventions at different times, or they were just too small and therefore scientifically were underpowered to actually show that they were, effective. We have a lot of guidelines, but the problem about this is it usually ends up being based on expert consensus. And one of the issues for me is that the expert consensus is based around what professionals think. We rarely ask people who've got post-stroke fatigue what the issues are. So again, we've got recommendations, but based on experts who are professionals. 2 papers I would pick up. The Hinkle paper published in 2017 was another review building on the work of Wu, and again concluded there's not much out there. And we did a scoping review in 2020 to pick up and mop up any of the literature published since the Hinkle review. And the bottom line is that there may be some studies out there but they really don't give us direction. So this is a problem. Okay, so what are the facts about stroke? So this is where we have audience participation time. And I'm going to ask Hokman if he could launch a poll, because I basically want to know what you think about the numbers of people who have post-stroke fatigue, who have fatigue. What percentage of people do you think? And if you don't know, just hit a button, because it really doesn't matter. It's either going to be right or wrong and you won't be lynched. So what do you think? So Hokman, you can tell me when you're ready to give me an answer.
Okay, the results should be on everyone's screen now. Can you see it, Professor Drummond?
Yes, I can see it. So most of you think it's about 50%. So I am well impressed. I am well impressed by this audience, because you are right. What we are saying is, and my screen just decided not to move on at the moment, but let's see where we are. The incidence of fatigue is accepted to be approximately 50%. So well done, you. So the difficulty we have is, if you look at the literature, the variation is between about a quarter of people to about 3/4 of people. And the difficulty is how you define fatigue and when you measure it. But what we say is that around 50% of people at 6 months after stroke will have fatigue. But another thing just to throw up to you, they're not all the same people. So if you look at the trajectory of people, this is a study that we did in Nottingham called the Not Fast study. And what we found was that pre-stroke, some people had fatigue already. So for some people, it's not a completely new condition. What we found at 4 weeks was that in our sample, 43% of people had fatigue. And at 6 months, we find this magic 51%. And these were people who filled out a questionnaire. So it wasn't us looking at them and deciding this was their judgment. But the thing you have to remember is that for some people, they had fatigue initially and it recovered. And some people only started having fatigue later on. So don't always just think it's the same group of people with fatigue. The evidence that we have suggests that people change, that some people recover, and that some people who didn't have fatigue start to have it. Okay, I'm going to ask you another question now, and this is a kind of a double bluff question, because you're going to think, oh, is she asking it because it's important, or is it important, or what's the answer? So the question is, do you think post-stroke fatigue is related to increased chances of mortality? Do you think that's true, or do you think that's false? In other words, are people who've got post-stroke fatigue more likely to die earlier than you'd expect? Oh, difficult. Am I bluffing? Am I not? And the answer is the majority of you think it's false, but 44% of you think it's true. Okay, let me move on to my next slide and the answer will be revealed. The next slide's thinking about moving on. Fatigue is linked to increased mortality. Now that I think is quite a shock to most people, but it is. And the reason is probably not a direct link, but it's what we would call a surrogate link. So if I can step you through it, we know that people who are fatigued are less likely to make the best outcome because they are unable to participate in rehabilitation, they're unable to practice, they're unable to make their best functional outcome. And across the board, we know that people with a poor functional outcome are much more likely to have increased mortality. They're more likely to be very disabled. They're more likely actually to need supportive care. So this has been known for many years. This study was first published in 2002, and people really didn't believe it, but this has been replicated. So actually, again, the whole concept of post-stroke fatigue is not something we should be taking lightly. A couple of quick facts for you. It's not related to site of stroke lesions. So some people will say to you, oh, this person has had a right CVA or they've got a left hemiplegia, they're more likely to have fatigue. This is simply not borne up by the evidence. So many studies don't really look at site per se, but the studies that have, or the evidence that's coming out from them, suggests there's no strong evidence. So bottom line is, if someone has a stroke, and it doesn't matter where the lesion is, they are just as likely to have fatigue. Fatigue is not linked to taking particular medication. But having said that, if you even look at your packet of paracetamol, you'll see that it'll warn you about fatigue, because fatigue is related to everything in medicine. But this is a really lovely study done by a French group, by Ponchel, and what they did was they looked at the influence of medication on people who were fatigued at 6 months. And rather like a lot of the literature that you have around falls, etc., what we know is that post-stroke fatigue is related to the number of medications that you're on, not with particular medication. So you shouldn't be thinking, if I'm taking X or Y, I'm more likely to have fatigue. Always I get questions about statins, and there are groups of people who think that there is a link between statins and fatigue, and that is simply not in the literature, and that is not being borne out by studies that have been done. So at the moment, all we can say is there's no evidence to support that. And the other thing we should say is, do not stop taking your statins. Do not on the basis of thinking it's related to fatigue, because the evidence for taking your statins is very much stronger than the relation to post-stroke fatigue. Another fact, there is a direct link between depression and fatigue. And absolutely, we know this. What we don't know is a chicken and egg situation. So we know that if people are depressed, we know that they're fatigued. But what we're not completely clear about is, if people are fatigued, are they likely to go on and be depressed? And there is some issues around that. However, although we know there is this link with depression, we know there's a much stronger link with anxiety. So people who have post-stroke fatigue are likely to be more anxious. Again, this is a study that we did in Nottingham, predicting people who had post-stroke fatigue and what variables might have been affecting that. Now, what we find at 4 weeks, and I have no idea why having a partner would be related to fatigue, although there's theories about if people have to do more, are they less likely to be fatigued? But that's a theory as opposed to actually something we know. But what was really strong at predicting post-stroke fatigue at 6 months was, again, what we've said about people having a poor functional outcome. So again, that's a chicken and egg, and definitely higher levels of anxiety. This is a big take-home message. So for all of you therapists and you doctors who say to people, yeah, your fatigue will resolve in the first 6 months, or it will resolve in the first year, this is simply not true. This is quite an old Cochrane systematic review published in 2012, but it said that people can have fatigue for much longer. And in fact, since that, the study by Yurtsberg showed that people had fatigue 6 years after stroke, and we have patients within our study group who've had fatigue for 10 years. So this is simply not true. And one thing that we do know is that there do seem to be links between fatigue across a number of conditions. But of course, it's difficult for us to know as researchers because we are looking at this, trying to be objective, and we can really only work with what people tell us. But what we do know is that there are these big similarities across fatigue in conditions such as head injury, MS, RA, and cancer. But there are fewer similarities with chronic fatigue syndrome and long COVID. And all I'd say to you is you have to be very careful, because what we seem to know is that people who have fatigue with a viral etiology or pathology, that seems to be different. I'm going to come on to that again later. Okay, so we've talked a bit about fatigue and what the facts are. What are the implications? And here I'm going to join together two studies that we've done around this. One of them is a study where we took people who scored highly on fatigue scores. They were 6 months after their fatigue. They all had mild or moderate stroke, and they were in a catchment area, so we could interview them face to face. And the second is a study where we said, if you think you've got fatigue, we'll talk to you. So you just decide whether you have or not. At any time point, anywhere in the UK, because we were doing it online because of COVID. And we also included people with aphasia, who are often excluded from these types of studies, but where there may even be indications that people with aphasia have more post-stroke fatigue than the rest of the stroke population. So when we asked people about who's talked to you about your fatigue, the responses were that people really hadn't, that nobody had spoken to them or mentioned it, or that they then had to go and find literature themselves to find out about this thing called fatigue. People had mentioned it and people had said, well, it's something that's happened, you know, it'll take months, it'll be fine. Or they recognized that they had a more pressing medical problem that needed attention, so it hadn't been addressed. When we said, how does it affect you? Honestly, the stories that people said were really very sad. This fatigue had really affected their whole life. It affected how they were going to plan their day, if they had special events. It was interesting the number of people who find shopping a really difficult experience with fatigue. And that's probably linked to how much information is being thrown at them when they go to the supermarket, and there's lights and there's noise and they've got a list and they're a different environment. This seemed to be something that people particularly find difficult. And also people just think it affected almost their personality of who they were. And the other thing to say is that fatigue is not just about people feeling physically tired. We know that people have this mental fog, so that they are so exhausted, it almost affects their thinking processes and how they make decisions. And again, many people said that they felt eaten by their fatigue, and they knew they had to manage it, because if they actually picked a fight with their fatigue, they realized that actually they were going to pay for it. And that was a word that people used, I'm going to pay for it. And I think this is a great thing that someone said to me. This guy said to me, you know, when I finish talking to you, I'm going to lie down and recover. And I'm not going to lie down and put the radio on, or I'm not going to watch TV, which is what you probably do when you rest. I'm going to have to lie down almost in a dark room to charge my batteries. And I think that's important that we recognize this, because a confession here. So when I'm trying to rest in the evenings, I drive my husband mad because I watch really trashy TV like Dr. Pimple Popper, or I'm so sorry to admit that I'm actually slightly addicted at the moment to Married at First Sight, which is horrendous. And don't ever anybody even tell me that I'm watching it, because I shouldn't be. But that's the way I relax and I charge my batteries. But for many of these people, they can't do anything outside, just lying there almost in a dark room. And it's important to recognize that. And again, this is a family problem. It affects people's carers, their friends, their family, and people say things like, if he doesn't manage his fatigue, then I'm going to have to pay for it. I'm going to have to manage it. And again, people saying really sad things about, we used to do things together, but now I have to do them by myself. Or people saying, I just don't bother anymore either. So that was the experiences of people with post-stroke fatigue. What we did then was that we interviewed 20 clinicians who had experience of working with people with post-stroke fatigue. And actually this paper has just been published this week. And these are the sorts of issues that the therapists were raising. They were raising the fact that they felt their role was really around education and around telling people that they had to accept this because they had to manage it. It was around the fact that they felt people should be able to talk about it more, and that many people had this condition and no one had talked to it and mentioned it even before. But they also knew there was a lack of evidence about what they as therapists should be doing with their patients. And that is the big question. What do we do with people with fatigue? Because there is no evidence to guide us. There are recommendations, but there's no evidence. Now, I think at this moment, I will just say it is important to recognise that within fatigue, there is some debate. And there was a paper published in 2011 in The Lancet. Now, this is particularly around people with chronic fatigue syndrome. And there has been such a controversy around this paper. And again, there was pressure on The Lancet to withdraw it. People did not like some of the trial aspects. This paper concluded that pacing, which is where you spread out your activities, was not effective. And that people, again, remember this is chronic fatigue syndrome, felt that cognitive behavioural therapy was quite important and that exercise was important. When I was preparing my slides and I submitted them, I was raising the fact that there had been this lack of agreement in the NICE guidelines, which had caused the guidelines. But we now know this has moved on. NICE have now said they will not publish these guidelines, and there is a furore. And again, I don't really want to present positions because I'm not involved in it, but it seems that there is a real split between people in this committee, between experts, expert patients, expert professionals about the guidelines. And this is really unfortunate, and we don't want to get in this position with stroke. So what do we do, and what are we actually doing? I would just like to say to you that this is unpublished data and we will be trying to get it published, so please don't screenshot it. Please don't pass it around all your friends. But we did a national survey during COVID. We had over 300 professionals answer it, and we said, what do you do with these patients? What do you do? In the absence of any literature, what are your strategies? And again, remember, there's an indication from a study that pacing didn't work, but that is what we are using by most therapists in the UK. So asking people to spread their activities out on a daily basis or on a weekly basis so that they could conserve their energy. And that was the #1 thing that therapists recommended. The second was keeping a diary. So people called it a fatigue diary or an activity diary, but trying to ask people to keep a diary. The difficulty that we find with this as clinicians is there's no point to saying to Mrs. Smith, keep a diary, if the therapist doesn't talk to her about what she's recorded and help her understand it. Because, you know, unless someone knows what they're looking for, it sometimes is not very helpful. Mm-hmm. And the other thing that came out really highly was educating the patient and their family that this was really something that they had. They weren't being, frankly, a wimp. They didn't need to get over it, you know, man up and actually just push through it. This was a real problem and it had to be managed. But one thing that we would say to you is from our survey, we were appalled at the variations. You know, some people were seen once. Some people could be followed up for 18 months. And some people could just have an open access to a therapist, and some people had no follow-up. So one of the things that we know that people need to do is to assess their patients. Now, if you think the literature around defining fatigue is confusing, you've seen nothing yet. So this is the same scale. People talk to you about the fatigue severity scale, and some people talk about the fatigue assessment inventory, and they're the same thing. And often people don't realize this. But isn't this, if you were trying to confuse people, isn't this a really good way to do it? And the reason this is so confusing is that there is a long scale, but there's a shorter scale with 12 points. And you can use the 12 points just as effectively as the full scale. And frankly, if you've got patients with fatigue, asking them to complete a 29-point scale is probably not something they're going to be good at. So we recommend the 12-point scale. And I would really encourage you to use this with your patients because it's dead simple, it's free, it's cheap. So you can benchmark what people are feeling. And essentially, people are handed a piece of paper that says, these are statements about fatigue, score them from 1 to 7, and answer on the basis of the last 2 weeks. And what we know from previous work is that if people have got a score greater than 36, this is clinically significant. In other words, we recognise that this is a clinical issue. But having said that, if people are getting a score of above 30, there probably is some intervention needed. So this is the scale. So you can see these are quite simple questions. Simple questions like, I am easily fatigued. Do you strongly disagree? Do you strongly agree? And the other questions that are there, fatigue makes my other symptoms worse. Fatigue is amongst my most disabling symptoms. So this is quite an easy questionnaire that you can give to people to benchmark where they are. The other thing is you need to take a history and you need to talk to people and ask them, do you have fatigue or do you feel tired a lot? And is the tiredness very difficult to manage it? You need to find out, is their fatigue physical? Is it a brain fog? And if it's a brain fog, does it affect their thinking? Does it make them more emotional? Do they have good days and bad days? Do they have a trigger point? In other words, do certain activities make it worse? And don't think that everybody does have a trigger point and they just have to find it. Some people don't have obvious things that make them worse. But some people recognize things that they can do, which makes their fatigue better. They just have to recognize it. And if you're getting people to keep a diary, then just think about how this is going to be looked at and who is the diary for. Okay, so what is our approach to this thing called fatigue? It's definitely taking a history and it's definitely assessing people. But after that, it's just very unclear. So there are people who think nutrition is important, and nutrition is probably quite important because we know in the general population that a bad diet is not good for you. But does it link to fatigue? It's not that clear. We do think that rest and sleep is an issue. So if people are not getting refreshing sleep, that may be something we can do. But honestly, a lot of the people we see have tried all the obvious things. So we do need to think about whether this is helpful or whether we're just teaching, basically people how to suck eggs. There are some interesting studies around exercise, and this is particularly in MS. Some people who've got fatigue show an improvement, but again, in stroke, the evidence is not strong. It's a very small sample of people and quite young people. Medication, some people are looking at curing post-stroke from the view of medication, but I think we're quite a long way off that at the moment. We know it's linked to mood, so one thing that you should be careful of is that your fatigued patient is not clinically depressed or clinically anxious, because that may be something you can help with. Pacing, I think the jury is out. Some people find it very helpful, but at the moment there's not a lot of evidence around it. And the so what? Is there something that we're missing that we don't know about at the moment? So what are the key points? If you've gone to sleep through my whole talk, this is the point where you wake up and I tell you really what you've missed. And what I'm saying to you is this is common and it affects people across their whole life. It's not trivial, it's really significant. Our current evidence is weak and we need to look much more at interventions, and that's what my group are planning to do. Survivors want to talk about it and they need people to talk to them about it because they need to recognise that this is a problem. We need to assess people, and in the absence of research, we probably need to get people to try things out to see if it suits them. And one thing that both patients that we talked to and carers and professionals said is don't underestimate talking to people about it, because it's really important. And also it's quite important for the family because it legitimizes the problem that someone is having. And so the family can recognize that mom, dad, husband, wife is just not being difficult. And the one thing I would say to you about this area is I got into post-stroke fatigue research quite late in my career. And I got into it because it seemed a bit nebulous and vague, and I thought, how would I look at this? But the more patients I talked to, the more I realized that this really was a problem. And we have done some co-design workshops with large numbers of stroke survivors. And I remember one gentleman saying at the end, thank goodness someone is listening to us. Thank goodness people are recognizing that this really is a problem for us. And again, the one take-home message that I would make to you today is to recognize this is a real problem for many people. So thank you very much. I hope you haven't fallen asleep. I haven't made you extremely tired, and I'm really open to any questions that you have. Thanks very much indeed. Thank you.